Okay, I think I've got everybody. So hi, everybody. Welcome to our AutismBC talk on autism and medication. Today, we're glad that we have invited Dr. Francois Prue with us here. Just a brief introduction of Dr. Prue. He has completed medical school in Montreal before moving to the West Coast, where he completed psychiatric postgraduate training at UBC. His medical practice is focused on developmental psychiatry and on the assessment and treatment of children and youth with neurodevelopmental disorders and comorbid emotional or behavioral disturbances. He is a consultant child and adolescent psychiatrist at the BC Children's Hospital Neuropsychiatry program and is the medical lead for the Lower Mainland Developmental Disorders and Mental Health Services team. Welcome to our AutismBC talk, Dr. Prue. And well, in general, just gives you some background because medication for autism is a topic that is constantly come up at our community groups and general inquiries across all ages of autistic individuals and their families. I think families and self-advocates usually feel that they're not really provided with much information on medication and autism and how it can support our loved ones. So here are some questions for you. The first question that I have for you is there any medication for autism? And what are the different types of medication usually prescribed for autistic patients?
All right, thanks, Lindy, for the introduction. So it's a pleasure to be here today. I'm happy to give a bit of information about this topic. It's true, I think there's a lot of unknowns. There's a lot of demand for information, and I think on some level, there in some corners there's still a lot of stigma, unfortunately, associated with not only with mental conditions, I guess you could say with autism itself, but also specifically with the use of psychotropic medication. So I'm happy to answer any question and relieve any worries if that's possible today. So to go back to your question, Lindy, so what medications there are for autism? I thought maybe it'd be good at this point if I'd share some slides. So let me pull that up. So I put, before I get to that question, Lindy, I just put a cropping, like a copy paste there of the screen from the Autism Speaks website. Many of the parents on the talk are probably familiar with that website, with that organization in the States. So they have an excellent one section of their website. The web address is up there, specifically deals with medical needs, and there's a lot of resources there about medications. There's actually two good resources, two PDF documents that you can download from their website, specifically about the use of medications. So one of them is meant to be a decision aid for families that are thinking about the pros and the cons of using medications for their child or their youth with autism. And the other one contains more general information about some of the benefits, but also some of the challenges and how to overcome them, some of the challenges that may be associated with medication use, from things as simple as swallowing pills whole, if that's a challenge for a particular child or youth, and that's necessary for a particular medication, all the way to the various side effects that can happen with some of those medications. I wanted to start by giving them credit, Lindy, because I'm going to use some of the material from those two documents. Sure. In the slides that follow. When people come to see me, because it's usually because their child with or their teenager with autism has either subjective complaints about how they feel that they don't like themselves, or because adults or people around the child or the youth have concerns about the behavior of the child. So part of our job, a lot of those subjective negative emotions or those problem behaviors are very non-specific. They could be masking a breadth of different problems. Some of them might be psychiatric in nature, some of them might be mental health in nature, but often it is the case that they're not related to mental health conditions or to psychiatric conditions. So it's important. One of the questions in the list of questions that you've submitted me, I think, Lindy, had to do with who do I go to? Who do I see? How do I get access to assessments for problem behaviors or mental concerns for my child with autism? And the answer is always, from my part at least, a resounding go to your GP, go to your pediatrician first, not simply because child psychiatrists are far and few and we're difficult to access, but because it is actually critical, it is crucial that a physician with good, solid general health skills and knowledge assess your child before we make the call that it would be good for them to see a psychiatrist. It is often the case, I've put on that slide, it's kind of busy there. These are slides that I use to teach residents, to teach medical learners about psychiatric assessments of youth with autism. But all that I wanted to show in those slides is that we heavily emphasize at the very top there, we need to rule out, we need to see if there's any sources of pain or discomfort, if there's any physical health problem that could be contributing to the child experiencing those negative emotions or displaying those problem behaviors. So it's crucial that you start by seeing a GP or a pediatrician, and then eventually getting a referral to more specialized mental health resources. The next slide, I think, is a bit more pertinent to that question you were putting to me, Lindy. So, are there medications for autism, and what are them, and what are they for? The medications, the psychotropic medications that we are going to use in autism, what can they help with? So this is a slide that many parents on the call, I think, may have seen, or some variation of that slide. And in some other talks pertaining to autism, it's a slide that's meant to represent the core symptoms of autism, and in dark blue circles in the middle. And this is pre-DSM-5, so it includes language impairment because, anyways, for historical reasons, when Asperger's disorder was a separate condition. But the point being, the core symptoms of autism are twofold. On one side, there's the social deficits that you see on the upper left corner, and then slightly at the bottom, the repetitive behaviors. So these are the two areas of core symptoms of autism. And unfortunately, as many people on the call may already know from the education that they've received, there are no pharmacological treatments for those core symptoms of autism. So there are no medications that will improve the core social deficits in autism. And I think that's relatively, widely known, and it's relatively rare that I get somebody coming in with that kind of expectation that we can prescribe something that's going to relieve those social deficits. Sometimes I find like we may put less emphasis on the second area of core symptoms of autism, which is the area of restricted, stereotypical, repetitive behavior and interests. So that is also an area of core symptoms of autism for which there are no medications that have been shown to provide benefits. So medications for so-called repetitive behaviors, that's not, unfortunately, an area for which we have useful pharmacological treatment agents. And then in the sort of paler shade of blues all around the core symptoms, you have a so-called associated symptoms that are not core to autism, but that can co-occur on the periphery for some individuals with autism. And that includes some bona fide psychiatric, non-psychiatric conditions, such as depression, anxiety disorders. One that's not there, but that perhaps should be there, is obsessive compulsive disorder. That can co-occur also in addition to autism, with autism on the side. Hyperactivity, as in attention deficit hyperactivity disorder, or inattention as part of that condition. And then there's a known cluster of problem behaviors, disruptive behaviors, that is known, that perhaps doesn't sort of add up to a classic psychiatric condition, a classic psychiatric diagnosis, but a cluster of associated disruptive behaviors that is known to co-occur and cause problems in some youth with autism. And that's the area that includes aggression, specifically reactive, like emotionally based reactive aggression, physical aggression, and self-injurious behavior. And then the word tantrum is there, which will have a negative connotation, maybe a dismissive connotation to some people. I prefer to use the word outbursts, so outbursts of intense, sudden negative emotions. So all those three things together are sometimes subsumed in the literature, or by some practitioner. You're going to hear sometimes people talking of quote unquote irritability in autism. I'm a little bit, I don't really like to use irritability. I think that it may lead to confusion, especially with my colleagues in psychiatry and that are not outside of developmental psychiatry or medical colleagues, because a persistently irritable mood, like a child or a youth who is sullen for most of the day, for most days of the week, or grumpy for on a pervasive way for most of the day, for most days of the week for a prolonged period, that's actually more evocative of major depressive disorder. But I think what we mean when we use the word irritability in autism is this cluster of aggression, self-injury, and outbursts of negative emotions. So these would be like these sort of paler shades of, and I think I forgot an important part, sleep, which now with all the people joining in, I don't think sleep is on that slide either, but sleep, outbursts, aggression, self-injury, anxiety, OCD, ADHD, depression, and also I will add one last one, tics. So tics, these would be areas that if they are present, and especially if they are impairing in a child or a youth with autism, these would be areas in which we would, there could potentially be pharmacological options that could provide relief to those symptoms. And then, so just to recap, so that's basically a recap from the other slide. So core symptoms about the things that people might come into me thinking that medications might help. In terms of core symptoms of autism, unfortunately, there are no proven pharmacological treatment to relieve that. So that is unfortunately not something that we can offer with medications. It's super important to rule out, because to rule out causes of physical pain or discomfort that could be contributing to disruptive behaviors or negative emotional states in a child or youth with autism. So it's super important to talk to your GP or pediatrician. And then there could be non-psychiatric medications, as the case may be, that could help with those medications. And as an aside, sometimes medications prescribed for other conditions can have psychological side effects. For example, seizure medications can have psychological side effects. So that is also something that we may need input and help from our non-psychiatry colleagues or your child's primary care provider in the community. And then, as I mentioned, subjective or behavioral symptoms of comorbid disruptive behaviors or psychiatric conditions could potentially be amenable to treatment with medications, with psychiatric medications. But there are actually non-pharmacological treatment as well that are often available and effective for many of those comorbid mental health conditions, such as anxiety, depression, or tics that co-occur with autism. So medications may not be the only option. And then in terms of disruptive behaviors, when we're talking about more non-specific aggression, self-injury, frequent and impairing patterns of negative outbursts, then medications can sometimes provide relief, can sometimes be helpful and improve the overall quality of life of the child. But it is in that case super important that we have a serious look at other treatment alternatives before jumping right away to medications. So many of you, if your child has been diagnosed with autism in early childhood, before the age of 5, you're probably familiar with behavior therapy, applied behavior analysis, early intensive interventions to target those core symptoms of autism and improve your child's adaptive functioning, your child's sort of life skills. But behavior therapy can have, or ABA can have, a role later on in the child's life if they're presenting with disruptive and impairing behavior. And that is often, I think, where the first line treatment is for such patterns of problem behaviors that are not associated with a specific psychiatric condition. That would also include, and that might, another useful intervention that I've seen provide a lot of benefit in terms of disruptive outbursts of negative emotions is an intervention that will improve the child's functional communication. So not only their speech in a very narrow sense of the word, like their vocabulary or their grammatical structure, but their successful use of communication in day-to-day life when that is impaired, that can reduce disruptive behaviors. That is often one of the factors that drives the disruptive behaviors. The core symptoms of autism, some people on the call may have heard of this or that promising chemical, molecule, hormone, or compound somewhere that somebody is doing research on that's been shown to improve symptoms of autism, maybe even cure it. Lindy was talking about my medical school in Montreal when I was in medical school, which I think was, I think that would have been late 90s, early century. Anyways, I remember sitting in lectures, and the big thing for autism back then was secretin, which is a gastric hormone, and that was going to That was, there were promising early results showing spectacular results in core symptoms of autism, and of course, more rigorous research over the subsequent years, unfortunately, killed any hope of this being useful for core symptoms of autism, and that's pretty much old, and nobody talks of that anymore. The most recent thing I think has been oxytocin. Maybe some people on the call have heard about research using nasal oxytocin in a spray. Oxytocin is the hormone that we give to pregnant women to speed up the contractions during delivery. So there was and it's related to the attachment system and pro-social emotions and whatnot. So there were research into its role in relieving some of the core symptoms of autism. But again, unfortunately, it's proven more rigorous research just last year. This journal paper has sort of, I think, nailed a coffin on oxytocin. I don't think we're going to be using that or anything in the near future, at least for core symptoms of autism. So the social deficits and the repetitive behaviors. So what are the medications then that we can use for these associated problems, these associated psychiatric conditions or problem behaviors that occur in autism? So this list is by no means thorough, both in terms of the types of problems or conditions we can use medications for, or the classes of medications that we can use, but just I think it's fairly thorough in terms of the most common conditions and the most common medications we use. So by far the most common reason that a child with autism will find themselves using and benefiting, seeing their quality of life improve with psychiatric medications is because they have ADHD on top of their autism. So different research samples, different cohorts of youths and different research papers vary in their percentage, but I think it's fairly safe to say that about 30, sometimes some people might say even 40% of children with autism may also have comorbid ADHD. And while the autism doesn't have a pharmacological cure, ADHD can be quite impairing on a day-to-day basis in the life of a child, in the life of their family. And medications can be effective and fairly well tolerated. So we typically will use medications that are part of a class called psychostimulants as a first-line treatment for ADHD, but there are other options to target either inattention, hyperactivity, or impulsivity. If you jump just a couple of lines on my slides there, compulsions, so repetitive behavior that's aimed to provide transient elusive relief of anxiety. So that's different than the more bread and butter repetitive behaviors that we see in autism. Compulsions may respond to antidepressant medication, and so does anxiety. So I've just below the line about compulsion, I've purposefully substituted the word or the convoluted phrase of anticipatory worries, fears, and avoidance related to fear, instead of using perhaps the more simple word anxiety, because I find that sometimes people have a lot of different things in mind when they use the word anxiety. And, my child might have anxiety, and could they be helped by medications for anxiety? But what medications, when we use medications for anxiety disorders, which in that case, we also use antidepressant medications for anxiety disorders. What these medications will specifically improve is excessive patterns of advanced worries about the future being in a few hours or this weekend or the longer term future, and bad things that could happen. Impairing specific fears or avoidance behavior that's aimed avoiding things or places specifically because of fear that occurs related to going to those places or doing those things. So anxiety and antidepressant can relieve anxiety disorder symptoms in that case. They can also relieve depression symptoms. Depression is a condition that typically, even in youth with autism, is a condition that tends to raise its head in after puberty in teenagers more than in younger children. And then tics are a specific narrow type of abnormal movements that's distinct than what we call mannerism. So some of your children with autism, you may have observed them rocking, perhaps when they were younger, like balancing their trunk in a repetitive way or flapping their limbs, like this sort of repetitive rhythmic movements of their limbs. So that's core to autism. It's not going to be helped with medications typically, but some children with autism may display specific types of abrupt involuntary movements that are called tics, and that can improve with medication, amongst other things. And then sleep. I guess to go from the top of the list with ADHD, probably the second most common thing that people come and seek help with medications is because of sleep problems. Otherwise, it would be anxiety. So anxiety, ADHD, and sleep issues are the most common reasons I think why people will seek psychiatric treatment if in a child with autism. Sleep, unfortunately, we do not have a lot of medications that have been shown specifically to help sleep. Melatonin would be one of them that you can procure over the counter. As you know, many of you may be using it. But we're quite limited in terms of medications that are specifically indicated to treat sleep disorder. Sleep problems in children with autism sometimes have another underlying cause. Once again, a key reason to get a pediatrician or a GP involved from the get-go when you have concerns about mental health or behavior problems in your child. Side effects, so that's often a big concern. So parents may be coming to me hoping for relief of problem behaviors, or the youth may be coming to me hoping for relief of subjective distress, negative emotions. But part of them may also be concerned about the potential for side effects, for adverse effects, for unwanted effects that will have a negative impact on their lives or their bodies from taking medications for mental health reasons. And the reality is that all medications can have side effects. We know from medieval medicines, from Paracelsus, that dose is what make a substance poisonous. So any substance, anything that I could give you could eventually, in some people at least, cause unwanted effect. That's unfortunately the reality. And the job or the work that occurs as part of a psychiatric assessment and as part of psychiatric treatment with your child's pediatrician or their psychiatrist is to balance what is overall what the degree of impairment caused by the subjective emotions that bother you or the problem behaviors, and how much that is impairing, and how much whether it's worth it to expose you or the child to the risk of side effects from this and that medication, depending on how impairing that is. And to change things, if it is apparent that you are experiencing, or your child is experiencing side effects, adverse effects from a medication that they're taking, whether a switch to another treatment could be beneficial. Again, this list is by no means meant to be exhaustive, but I think it captures most of the most common side effects from some of those medication classes. All of these medications can have very rare, sometimes very serious, but exceedingly rare side effects that are because of their extreme rarity or a very remote part of that risk-benefit assessment. But many side effects are quite common, and that should be included. That should be part of what you are aware, what you expect may happen as part of your decision to undergo treatment with that class of medication. The elements that I've put in red in that list are actually side effects that can be irreversible. So even if we were to stop the medication, those side effects may stay there even after stopping the medications. So I'm just going to make my screen bigger because because I'm having it's so small, I'm having trouble reading my own slides. So for psychostimulants, are the medications we give for ADHD, more commonly by far the first line medication. So that includes things like what used to be sold under the name Ritalin, and which is now called methylphenidate, and its various long-acting preparations such as Concerta, Bifenton, amphetamine preparations such as Vyvanse, Adderall. So stimulants can cause growth suppression. In fact, stimulants do, that's almost like a trade-off, like a guaranteed side effect. Stimulants will reduce with long-term childhood usage of stimulants through many years in childhood or most of childhood. It will end up chopping about 2 centimeters or half an inch off a child's final adult height. So that's a fairly predictable side effect. The concern is, and for the families that will choose to try that, to use that in their children, the trade-off is deemed to be acceptable because the symptoms of ADHD are so impairing that, and the relief provided is so good that it's deemed to be an acceptable trade-off. But it's important because rarely children may be more impacted than that by the growth suppressive effect, and it can reduce appetite. One of the person that submitted a question ahead of the talk was asking for suggestions when that happens, and I'll get to that. I'll have another slide about that. It can cause a bit of insomnia, and it can also have what I call psychological toxicity. So another chemical that's part of that class called psychostimulants that many people on the call, including myself, I have my my cup right before me, another of those chemicals that you may have experienced using yourself is caffeine, the caffeine that's in coffee. And as you may all know, different people have different level of sensitivity to caffeine. Like some people feel like if they have only one cup, then they feel jittery and they can't sleep even like 6 hours later. So some children will have a unique sensitivity to psychostimulants. We don't use caffeine for ADHD because it's too hard on the body, but we use the therapeutic stimulants. Some children will have psychological toxicity, so they may look like the child is jittery or a bit more labile a few hours after getting the medication. And that's usually a dose-dependent effect. So it just means that this particular dose is too high for that child. For ADHD, we may also use medications that are part of a class called alpha agonists, which speaks to receptors in blood vessels and in the brain that this medication targets. Medications that are part of that class include, there's only 2 in Canada, there's clonidine and Intuitive. And these 2 medications can cause sedation, lightheadedness, or cause or worsen constipation when that's an issue. Atomoxetine is sold under the name Strattera, and that's used for ADHD. And that one can cause, especially when those things happen with Strattera, it's usually initially, like on the first few days on a dose, it can cause a bit of low-grade nausea, reduced appetite, or headaches. Now, antipsychotic medications, we use them, I would say, in children with autism, for the most part, for disruptive, severe enough, recurrent, physically aggressive behavior, reactive, emotionally based physical aggression, self-injury, and excessive, severely impairing recurrent patterns of outbursts of negative emotions, although they can also have a bit of a top-up or add-on action on other things such as hyperactivity, tics, or compulsions. Antipsychotics are probably, of all the medications on that list, are the one medication where side effects can be substantial, and not only that, but they're fairly common. So it's easily a double-digit percentage of patients taking antipsychotics, like 20, 25, 30, 35% of children taking antipsychotics in the long run will go on to put on more than 5% of their body weight. Some of them may develop diabetes or cholesterol problems. And for that reason, I've put that little sort of syringe on the right because ideally, I know for a lot of children with autism, that's going to be very, very challenging, but ideally, it would be safest to use antipsychotics if we can do regular blood tests on the child every 6 months. Antipsychotics can also cause involuntary movements of a different type altogether that are very slow to occur, typically over many years of usage. And all of those problems, the involuntary movements, but also, as you know, gaining weight, it's easy to gain, but it's harder to lose. Even if we stop the medication, it's not going to magically go away. Just like any other type of weight gain, it can be harder to lose. And antipsychotics can cause a bit of sedation too. Antidepressants, which in children, especially prepubescent children, we're typically going to use for anxiety disorders, for fears, excessive impairing fears, avoidance related to fears or excessive anticipatory worries or reassurance seeking, or for OCD, I should have put there. So antidepressants can cause a bit of transient. Is typically in the first 2 weeks that you take the medication, there can be sometimes a bit of a low-grade abdominal pain or nausea, with some of them in particular a bit of diarrhea, or diarrhea is even perhaps too strong of a word, like loose stools, headaches, that is typically in the first few weeks of the medication once again. And antidepressants can also cause, similar to stimulants, in a minority of, a relatively small minority of youth, they can also have psychological toxicity effect. And then melatonin, I've added there, I've put a question mark. I think it's pretty safe to use. Many, I don't have a register, but I think probably most of my patients, or at least a third of my patients, are taking melatonin for sleep. I've used melatonin on myself, on my children, sometimes when we travel across time zones. I think it's probably safe, but I've put a question mark there because as many so-called natural product or things available over the counter, the reality is the data gathering about any potential long-term adverse effect is not the same as it is with prescribed medications such as Ritalin, such as methylphenidate for ADHD, that's been used widely in millions of children since the 1950s. So I'm not worried in particular about melatonin having long-term side effects, but sometimes that is a question mark worth perhaps emphasizing when some people are contemplating using other alternative medicines. So what are the potentials of long-term side effects of doing that intervention, and what's the basis? How do we know that it's safe long-term? a couple of points just to wrap up on my slides, Lindy, if you allow me. That I think did not come up in the questions that you sent me, but I do have a lot of families nowadays either having it done themselves, because you can do it. It's direct to consumer advertising, so you don't need a physician to order it. You can get it done, I think, in the States, and some people will get it done with a physician prescription and with Canadian labs. And I get ads on my own Facebook feed about what's called pharmacogenomic testing. So it's genetic tests, but specifically the idea is to genetic test to look at whether you're likely to experience side effects or respond more or less to this or that class of medications. So, and often the Facebook ads I get on my Facebook feed are quite, generous and promising in their, I remember reading the phrase like, take the guessing out of mental health treatments. And so there's the idea that, take that blood test and then we can tell you exactly which medication will make you feel better, like right away. And that's, in my view, completely out of line with what these tests actually deliver. So they cost a few $100s. I don't know if some of my patients are on the call, or I have no objection to you ordering the test or you taking it if you feel like you want to pay for it. But my advice is, I don't think you're going to think you're going to find that it gives you the information, the data that perhaps you were hoping to get. So I've yet to come across a single case where it's actually influenced what we prescribed following the test. And what I've put on my slides, so my professional organization, the American Academy of Child and Adolescent Psychiatry, recommends against doing that routinely. So pharmacogenomic testing. So just a random slide here for the person who was emailing Lindy about, I think they were saying their child is eating less or has growth suppression. And I'm going to guess they didn't say in the email, but the only medication really that would cause that is psychostimulants. So once again, this first line medication for ADHD. So that's actually a slide I took straight up from those PDFs that you can get on the Autism Speaks website. So I'd encourage you, they want you to log in, like you have to type in your email to get the PDF, but I never got any junk mail from them. Like they're pretty good. And the PDFs are actually useful. So, and there's a couple of pages in that PDF about specifically that. So what to do if the child's appetite is too much, there's too much suppression. So of course, so often there's a couple of simple things about meal times. So regular meals, and often like emphasizing the calorie intake when the medication is, before the medication kicks in and when it wears off. So the meals at the beginning and at the end of the day. Another thing that I'm originally from Quebec, I think, as Lindy said, and I've lived in South America too, where if you've been to Argentina, the kids are playing up at the park at 10 p.m. and then they go home and have dinner. So often like adding another evening meal, which you can call an evening snack, but it's an actual meal with meat and protein, like after dinner, to your child who's been eating less, perhaps through the day because of their ADHD medication, can help. And then there's a couple of ways to increase the caloric value of the foods that your child will eat. And that's also part of what I was doing when I was there, so dealing with malnutrition. But often, like there's no reason that your child should be on any so-called low-fat foods, like low-fat yogurt, low-fat milk. Like everything should be full fat. And you can also add like a spoon of cream, depending on what it is, a spoon of oil, an extra egg in the pancakes. And there's a number of other suggestions there in that brochure. I think you'll find it useful. For people that have such problems, I was a bit sort of hesitant to put that slide there. That's the question we got, but I guess by a ratio of 5:1 in terms of appetite and weight side effects, yes, the stimulants can cause low appetite and low weight, but the problem that I run into much more often is antipsychotics causing too much weight or weight gain and too much appetite. If your child is on psychiatric medications and is experiencing one or the other, in addition to seeking guidance from your GP, your pediatrician, from reliable sources such as Autism Speaks and what I've put on those slides, you can also request from your physician a referral to the Mental Health Metabolic Program. So it's called the Mental Health and Metabolic Program at the BC Children's Hospital. They will see patients from across the province via Zoom or in person with a team of dietitian, GP, occupational therapist, and endocrinologist if it's necessary. It's specifically to help children that have weight-related side effects from psychiatric treatments. And then my last slide. So again, this one did come up actually in the questions, and I probably does, a month does not pass before I get another request about cannabis or cannabinoid compounds for to address this or that problem in a child with autism. So, and you can, for those that are interested in pursuing that, there's at least one, if not by now, a number of, I think, reliable, reputable physicians, who may not just prescribe it on demand just by knocking on their door and showing up at their clinic, but a green leaf with Dr. Jane Finley here in the Lower Mainland. So that is definitely something you can explore. But if you ask me what my opinion is, my reading of the literature is it doesn't, there's nothing really at this point to suggest that it's going to offer benefits. There's consideration about the potential harms of using cannabinoids in kids with autism. To an extent, I share those concerns. I think to an extent they're a little bit overblown, and I'm certainly grateful that there's ongoing research in that area, because the harms about the potential for cognitive decline and all that, that's also a lot from the use of street obtained cannabis, like whole plant cannabis from the streets, and this is observational studies. So there's that cohort in New Zealand and whatnot. So there's a bit of, yes, children who were exposed to cannabis early and frequently experience a noticeable cognitive decline, but the youth that started to use cannabis early and frequently may have been self-selecting themselves for some reason. Like there may have been youth with other problems that could explain why they eventually experienced that small cognitive decline. So there's a lot of problems, I think, about the research about the concerns about the potential harm. Don't get me wrong, early cannabis use definitely can have harm. I'm not saying it's totally always safe. I think there certainly is a role for ongoing research in that area. And I do think it's premature to prescribe it, certainly for any specific psychiatric diagnoses, like for depression or anxiety disorders, and for disruptive behaviors in autism. The latest sort of paper that made its way in mainstream media was published late last year. This is a team from Israel. I've put it right above me on the slide there. There's one graph in the paper. Basically, this is a research team that looked at different outcome measures, and on one of the outcome measure, there seemed to be some positive effect. But overall, the data gathered by that research team in that paper, I think, does not support the use of cannabis for disruptive behaviors in autism, is, I guess, the bottom line. And the other sort of bottom line is, again, I've put on my my right here again, my professional organization, the American Academy of Child and Adolescent Psychiatry, does not advise against the use of cannabinoids or cannabis in children with autism as of today. There's one, probably the most interesting research paper that's in the works right now. I think they anticipate completion in 2023. Is there's a couple of them. There's one in San Diego, but there's one that I think is going to be, I don't want to bore you with my analysis of scientific literature, but there's a lot of problems in a lot of those papers. But there's one going on in Colorado, which I think will be, you can watch it. Like, once the study from Colorado on cannabis and autism, cannabinoids and autism, cannabidiol, I think in that case in particular, cannabidiol and autism from Colorado, once that gets published, I think we're going to get perhaps not final answers, but a lot more useful information on where to go with that. And yeah, so I guess I'd prepared those few slides, Lindy, and I think I went over some of the questions that some of the people had, but maybe we can go down the list and see if there's more questions that
well, actually, we have a few questions here. So above the age, when would you consider it's a safe age to start medication, and what to look for?
Yeah, so I guess very good question. As an aside to that, often the concept comes off of using, some parents will get worried about the concept of using medications in a way that's so-called off-label. That's mean outside of the Health Canada approved use, which is already a little bit narrower than the American FDA approved use. But sometimes we have to use medications even outside of FDA approved use. And in Canada, Yeah, in Canada, there's nothing really approved. No psychiatric medications whatsoever is approved by Health Canada for use in children younger than 6. But that being said, there is no such an hard and fast rule. So we often will use, especially in developmental disorders, like in youth with autism, we will often use medications outside of the Health Canada or FDA approved label. And that doesn't mean, if it's off label, it doesn't mean that there's no research to support it. In order for the drug manufacturer to obtain the Health Canada label, some private business like the drug manufacturer has to expend money to go through that process with a regulatory authority. And for a variety of economic reasons, often manufacturers will not go through that hassle because it's not going to be profitable at the end. But there can be a lot of research, in fact, supporting the use of many medications outside of the Health Canada or FDA approved labels. And there is research supporting the use of psychotropics below the age of 6. I would say probably the very youngest kid that I've ever prescribed or seen being on psychotropic was age 4. And again, it's not to say that it's a hard and fast rule, but definitely the research, the younger you are, when you go below age 6, the research is less. And for the research that there is, and that's typically is going to be for stimulants in hyperactive preschooler who are very, very impaired by the hyperactivity, and where the hyperactivity has been resistant to behavior therapy interventions. So that's one situation, perhaps in addition to anxiety disorders and some severe anxiety disorders where we may consider using psychotropics. But unfortunately, even if we do, the research would suggest, for example, in psychostimulants, that the benefits, while they may be there, they're going to be smaller than in older children. And the side effects, while they may not be there in some preschoolers, they are a bit more common than in older children. So it's not a hard no, or there's no hard minimum age, but definitely when you are younger than age 6, it becomes a bit trickier. Yeah.
Okay, and then in terms of the dosage, is there a difference in like mental health issue in autism versus like general anxiety or general mental health issue?
So, so I guess yes and no. So it is true that anecdotally we often see that children with autism are more prone specifically to the psychological toxicity side effects of some psychotropic medications. So for that reason, we often recommend to start at lower doses. But at the same time, it is very common, if not, children with autism will most commonly eventually require higher doses, if not similar doses to neurotypical children, to eventually respond to the medication. So yes, we have to be concerned and start lower, but at the same time, we have to not be sort of closed off to the possibility of going higher if needed to get the results that we're hoping to get. Yeah.
I see. So for like, okay, we can measure for people who can tell you how they feel, but for the non-speaking community, how can we measure or like anything to look for to see if this is the right medication, right dosage for them?
Yeah, well, when I use the word when I hear I read the phrase non-speaking, I'm wondering if there's other ways that they have to communicate, because then of course
some of them, yes.
Yeah, in someone who may be hearing impaired or who uses augmented communication, then that would be the way to obtain, if we are looking for subjective information from them to assess for side effects or benefits from the medication, that would obviously be the way to go about it. But of course, probably the person is talking about individuals who are disabled in all areas of functional communication or substantially disabled in that area. So often we are going to rely, so that's part of our jobs. We're going to rely on behavioral anchor, on observable anchors from the people close to the patient. There's forms, there's like journaling, diarying, like daily recording of some specific symptoms that we can have you do if we want to be really systematic about it. That would be perhaps the official or recommended way to go about it. I always feel guilty when I ask busy parents to fill forms for me. So sometimes we're just going to rely on your sort of gestalt sort of appreciation on whether things are better overall since we last met. But there are ways to just rely on behavioral anchors, objective anchors of people who live with the child.
Mhm. Yeah. Okay, I think we can now go to our chat and see the question from the floor. The first question that I have is from Nikki, and the question is, I would like to hear about ADHD medication for a child with NF1, ADHD, ASD, concerns or things to watch for.
Yeah, so NF1 is definitely one where there's actually that's not the topic of today, but I guess it sounds like your child has neurofibromatosis type 1. So it sounds like your child, probably because they had visible, readily appreciable physical signs, they were tested for a specific genetic condition and found to have to have that condition. It's also nowadays it is recommended that every child with autism gets some form of genetic workup. And sometimes that is, if in the majority of cases, that workup will still come back negative, but more and more, like in up to 20% of children with autism with just a standard basic workup that does include some blood tests, we can find a genetic etiology for their autism. And that's one of the usefulness, one of the many sort of potential usefulness of having an etiologic, like a cause, a genetic cause for your autism. So in the case of NF1, the first line medication for ADHD would be methylphenidate. There is a good quality randomized controlled trial specifically in children with neurofibromatosis 1 and ADHD. The author is Francois, so same L-E and my first name, but it's their last name, Lefrancys. There's obviously no connection with me. They're from France, and I think it's maybe 10 years old. So there's a good quality RCT showing supporting the use of methylphenidate in NF1. And then in terms of side effects, the things to watch for if they decide to, if you talk to your child's physician, they find that it's indicated, because it's indicated for ADHD, not for NF1 or autism once again, right? Like it's meant to improve specific symptoms of ADHD. So if you decide to go ahead with that, the things to watch for would be the same things as neurotypical children or autism. So growth suppression, insomnia, and more rarely psychological toxicity. Another thing that I've not put on my slide, but stimulants like methylphenidate or the caffeine that's in coffee, it will raise blood pressure and heart rate. So again, it is safest. These are molecules, the therapeutic stimulants are specifically sort of chosen because they're less likely to have any dramatic impact on that, so long as someone doesn't have like a pre-existing heart defect. But it is safest to use those medications if we can track the child's blood pressure and heart rate once we start the medication. And I mentioned because some children will not, that's just checking blood pressure will be very challenging. And it's not a hard no that then we cannot use stimulants, but it is safest if we can't do that. Yeah.
So another question we have is, who do we see if a child turned 18? I suppose, can they continue to see you, like if they are with you before they turn?
Yeah, no, so child psychiatrists, I guess there's no, it's not necessarily a hard cutoff, like depending on different clinics, different hospitals, the cutoff may be 16, 17, 18, 19, 20, but definitely they're not going to keep seeing a child psychiatrist. The vast majority of patients, the model for delivery of mental health care in Canada is that psychiatrists are consultants. Psychiatrists have sporadic involvement in a patient's care. I'm talking about any mental health patient, and sort of continuity of care, including for mental conditions, is done by the GP. So some patients who are seeing a child psychiatrist may need to be transferred because there's ongoing medication adjustments of one kind or another. They may need to be transferred to an adult psychiatrist as they come of age, whatever that age may be at that particular clinic. But often what will happen is that eventually, children do get better with I would say the majority, I dare to say the majority of children, youths do get better with the treatments that we prescribe. So there comes a point where, happily for them, but sadly for us, we're okay to say goodbye. And often the conditions that we treat, anxiety disorders, depression, they can be chronic depression. So meaning there is a risk of relapse. So they may need a repeat reassessment down the road, and they can be referred in that case to an adult psychiatrist. Yeah, I guess maybe the person is going at also adults with autism may find that it's difficult to find somebody with a mental health care practitioner with specialty expertise in autism, and that is a reality, unfortunately. So there is no sort of specialized clinic or system, sort of segregated systems of care for adults with autism that exist at this point in the province. unfortunately. Yeah.
We have like
Yeah.
quite a difficulty getting a adult psychiatrist.
Mm-hmm.
Yeah, another question from the floor. Bobby is asking, I have a child with ADHD who is on the wait list for ASD diagnosis, and our pediatrician has prescribed Tiva clonidine in the evening to help with impulse control, and also a side effect that will help my child sleep. I'm uneasy about this as it's not a typical application for this drug.
So I want to honor if you're uneasy about something, it might be worth talking to your child's pediatrician. But it is a typical use of clonidine to use it for ADHD, and it will the bedtime dose. Perhaps the issue, I guess, if I'm reading your comments, if clonidine is going to be helpful for ADHD, it's going to have to be taken many times a day. So taking one dose of clonidine at bedtime is unlikely to have any impact whatsoever on ADHD, but it may help with falling asleep because it can be sedating. However, clonidine is a medication that we commonly use for ADHD. It's one of its sort of common use in child psychiatry. It's a second line after psychostimulants, but it's commonly used. But it has to be taken many times a day for it to be effective for ADHD. And it's possible that your pediatrician, so it's one medication that has to be started slowly. Because of that, I mentioned the side effects include sedation, a bit of it can lower your blood pressure a bit. So it has to be started very slowly. So it's possible that your pediatrician is just wanting to start with a bedtime dose for now. And over the weeks, over the months, we'll gradually add other doses through the day and increase them. Yeah.
Okay, so we'll go to the next one. And Lynn wants some examples of antipsychotics.
Yeah, so I guess that's a good point. I didn't really give any of, I spoke of classes, but I forgot to put examples. Yeah, so the ones, I think I'm reading some other person in the emails you'd send me, Lindy, was wondering whether risperidone and Abilify, which are the two most commonly used antipsychotics, cause weight gain. So risperidone and aripiprazole, which is the generic name for Abilify. These are the most commonly used antipsychotics in children with autism by far. These are actually FDA approved. So in the United States, they're approved, officially approved by the FDA to be used in children with autism for disruptive outbursts of anger, aggression, self-injury. Unfortunately, both, to go back to that question in the email, both can cause weight gain, diabetes, cholesterol problems, and involuntary movements, amongst other things. Abilify a bit less than risperidone, but this is a concern for both of those medications. Yeah. And the person was also asking what can be do to mitigate the weight gain. I happened to put the slide about suggestions to help the children on stimulants to eat more. But if you download that same brochure, there's another set of pages in that PDF about the children who have the opposite problems on antipsychotics. Again, if that becomes a bit intractable and serious, your physician, your child's physician, can refer them to the mental health metabolic program. Sometimes at the end of the road, there are additional medications that have been shown, that research shows will reduce the risk of weight gain with antipsychotics if we add them to the antipsychotics. Sometimes switching to a different antipsychotics for example, from risperidone to aripiprazole may help. But I guess, I'm sort of starting towards at the end of the list with adding medications to target weight gain and switching medications, but at the very sort of basic level in the home. And this would be like if you yourself, your husband is taking those medications for other indications, for bipolar disorder, for example, in the home of anybody, and certainly in the home of a child with autism who's on those medications, they're going to have there's going to have to be what's called portion control. So we're going to have to be very mindful about how much and what kind of food is available at what time of the day for your child to have access to, because that's often a big part of how the weight gain happens. Is these medications may sort of dull the feeling of fullness, and the child may be prone to eating more and more than they should, especially food that are starchy or engineered to taste good and to make people want to eat more of it, like processed food and snacks. And you're the physician that prescribed those medications will hopefully give you some counseling on how to go about that, because that is very important. Yeah.
Okay. Another question we have is, do you have any suggestion for a 16-year-old child who can't take melatonin due to hallucination and it's on 0.3 milligram nightly and still struggles with restful sleep for a full night?
Yeah, so if they cannot take melatonins, but they're still on it, I'm not sure I understand the
Sorry.
question.
That would be my question. I forgot to add that it's actually 0.3 milligrams of clonidine.
Oh, okay. Yeah, so that is unfortunately there are no like if I was just to give a lecture to physician colleagues about sleep medicine and sleep problems, there's no medication that's approved for treatment of insomnia that cures insomnia. So that is really a situation where there needs to be an assessment of what are the factors contributing to the sleep difficulties. A couple of things that I can think of just at the top of my head. So clonidine will help with falling asleep, but it's very short acting. It will go out of your body after 3 to 4 hours. And sometimes that create a bit of an adrenergic rebound. So sometimes that'll wake up some children even at lower doses than that. So I'm wondering if as the dose of clonidine got increased, whether those sleep interruptions, and if that's indeed the problem, because if the problem is falling asleep at the beginning of the night, but if there's sleep interruptions in the middle third of the night, I'm wondering if that got made worse by the clonidine increase. Another thing that's super important. So again, a comorbidity. Your child is not just autism. Like there's a lot of other things. A lot of other good things going on about them and about who they are as a person, but unfortunately other potential health problems that are unrelated to autism, and one of them would be obstruction in the airways, like as an obstructive sleep apnea. So that would be like one super important thing to rule out. A lot of children with ADHD will struggle with difficulties with falling asleep, like just without treatment, not because of the stimulants, even before they're on any treatment. And often it's not that treating ADHD causes sleepiness and puts them to sleep, but treating ADHD allows for their days to be more structured in a predictable way that will sort of stabilize their biological rhythms. And over time, over months, they're going to find that they fall asleep better at night. That's just anecdotally what I've seen happen. Another thing that commonly occurs in children with autism, but actually in a lot of it's under-recognized in my opinion, but specifically in children with autism, specifically ones that may be very picky about their diet, they may lack adequate iron intake and they may be iron deficient. And even often people think of iron deficiency and in their mind, even physician colleagues will link it with anemia because it can cause anemia where the person feels like short of breath and is pale and white. But even without any anemia, the iron deficiency is known to not only worsen ADHD, but also cause unrestorative sleep. Sometimes with restless leg feelings like at the beginning of the night. So that is really a situation where there has to be I'd find myself difficult to, I'd be very wary of suggesting any sort of sedating medication without knowing all the workup that's occurred around the sleep issues. Yeah. Okay. Another thing I'm sure like not everybody on the call is aware of, and even myself as a doctor, I'm guilty of like sleeping with my phone beside my night table, but it's of course electronics. So, your child is on melatonin. The brain normally does secrete its own melatonin from the pineal gland right in the middle there. And the signal that your brain has to secrete that is the lights going dim at the end of the day. But the intensity of light is inversely proportional to the square of the distance. So unfortunately with electronic devices, we hold them really close to our face. And if a child has access to an electronic device at bedtime, past dinner time, that may be enough light to cancel their endogenous melatonin secretion. So super important that there'd be like some limits around access to electronics as well. But I'm sure often nowadays everybody's sort of well aware of that. Yeah.
Okay, the next question we have is any evidence for omega-3 supplementation or gluten-free diets, dairy-free diets?
So there's evidence for gluten-free diets, and as you may know, in a condition called celiac disease, where it's going to relieve GI, bowel symptoms, and sometimes growth restrictions that are stemming from the GI symptoms. There's no evidence of gluten-free diets improving symptoms, behavioral symptoms in autism that I'm aware of. And I see right below, unless somebody else put dairy-free diet. So again, there's evidence of dairy-free diet in lactose intolerance or allergy to milk proteins. And specific conditions that, and then where the effect of the diet is primarily to relieve GI symptoms. However, definitely, if for example, a typical scenario would be like a nonverbal child who has unrecognized celiac disease, that will bother them through the day, and they may have limited ways because of their autism, amongst other things. They may have limited ways to regulate, to sort of fix how they feel, to make themselves feel better from the bother that they're experiencing in their body. They may have limited ways to communicate that in effective ways to other people, and that may show up as disruptive behaviors. So as with any physical conditions, and that's why I go back to my original slide, where do you start? You always start with your GP or pediatrician. We want to make sure that there's not anything, including celiac disease, who knows, that's bothering your child or the youth. And if there is such a real physical condition in them, which is diagnosable through specific tests if they're indicated, because they may not be indicated if the symptoms are not, and if the physical exam is not suggestive of celiac disease or that condition. If there is such a physical condition that's bothering them, then definitely those specific treatments for that are indicated. But in the absence of such conditions, I'm not aware of any diet, actually, really, of any kind improving evidence showing that it improves behavior or psychiatric symptoms. So omega-3 fatty acids. So different colleagues have different reading of the literature. I personally do not. I don't have a very optimistic reading about that. It's certainly not. I'm not aware either of any harm. So a gluten-free diet, a dairy-free diet, it could be tricky. It has a potential to be harmful in the long term for your child. So definitely, if you're going to choose to do that against medical advice, maybe talk to people about how to make sure that there's no nutritional deficiencies in the diet that your child is going to be fed. Supplementing your child with omega-3 fatty acids every day for 3 months and seeing if that helps. I don't think that's unlikely. That's unlikely to be harmful in any way. But I'm not aware of any. My reading of the literature on omega-3 fatty acids in autism is that there's no strong evidence of it being beneficial. So it's not something that I routinely advise. One thing that a lot of people are interested in various supplements and natural treatments. Like one thing that in my reading of it is there's a little bit more evidence. It's not like a miracle cure, a magic pill or anything like, and the literature would suggest modest effect, but there is some literature supporting the use of acetylcysteine supplements. But then again, they are available over the counter, but I would suggest that you talk to a physician before embarking on that. So it is an amino acid, but I'm not aware of evidence that would support the use of these restrictive diets.
Okay, my next question is, how long should we wait to measure the effectiveness of one medication and when to revisit it?
Yeah, so that's going to be dependent on which medication that is. So some medications, I guess, to start with the longest to kick in, it would be medications for OCD or anxiety. And antidepressants that we use for OCD or anxiety may take a good 2 or 3 months to fully kick in. That would be the same thing for atomoxetine or Strattera for ADHD. Antidepressants are going to kick in a bit sooner for depression, after 6 to 8 weeks. Alpha agonists like clonidine and Tunib for ADHD, if taken during the day. With clonidine for ADHD, it's going to kick in after 1 or 2 weeks. And then stimulants, so the psychostimulants that many people were asking about for ADHD, these ones will provide immediate effect. Like the day that you take a particular dose, you are supposed to experience the effect of that dose that day. Now, your doctor may have started your child on a very low dose just to make sure that he's not uniquely sensitive. So it is possible for that reason that for the first few weeks, you're not going to see any difference. But once the child will get to a dose that should be effective for him or her, then you should see the effect that you did the day that you take the dose. When I prescribe those, I explain that to parents, but I still, I'd still rather you wait at least a good week before of taking a particular dose of stimulants before you make a call on whether it's helpful or not, because children, like the rest of us, can have a good day or a bad day on a particular day for a bunch of other reasons than just having taken a new dose of stimulants that day. So, but after a week, and assuming there's no other significant disruptions or stressors in the child's life that particular week, after a week on a dose of stimulants, you should have a sense, I think, of what it does to them. So in terms of the duration it's going to take to kick in, it's variable on depending on which class of medication.
I see. So better to talk with your medical professional to see when to revisit it. Okay. Okay, so from Sandra, my teenager is on fluoxetine and risperidone for irritability and anxiety. Been trying to remove risperidone, but has difficulty because he's itchy each time we try to remove it. Is it safe for long-term consumption?
So safe is a bit of a it's a bit of a in a way it's a poorly defined word. So it's a little bit when we were asking Bonnie Henry if it's safe to be in school with COVID, like, well, safe, like, I guess lots of things can happen in safe. Yes, you can catch COVID, but it's less likely than in other settings. So definitely risperidone is known to have common long-term side effects. It's also known that many people, a high proportion of people, will not experience any long-term side effect whatsoever. But as I mentioned, easily up to 30% of children may put on significant weight. They may go on to develop significant weight. They may go on to develop diabetes or cholesterol problems. And there's also the risk of involuntary movements that may become irreversible. And these are very slow to kick in. The weight gain, I should say, I don't know how long the person has been on risperidone, but the weight gain on any given dose tends to, in my experience, anecdotally, it tends to plateau after 6 months. So it's not like I've been on this for 5 years and then suddenly I've gained weight. Like I would be thinking maybe there's another factor there. I guess I should say there's, like weight gain, diabetes, cholesterol problems. These are body conditions that have a genetic, meaning like a static risk that's already in you, where you may be more prone to diabetes or weight gain because of your genetics, and then we add risperidone and that may increase the risk. But then on the other side, there's things that you can modify, that you have some agency on to reduce the risk of those things happening. And these are, of course, things around diet and exercise. And then another thing that can make it safer is if the child is able to comply with some medical monitoring of the side effects. We would recommend blood work every 6 months while you're on risperidone, and to track your weight, your blood pressure every 3 months, to try to identify those things early and potentially intervene early on them. And then beyond that, like in any treatment intervention, it becomes a matter of whether the risks and what are the actual side effects, because some of my patients have gone on to develop diabetes, but chose to stay on risperidone because it just eventually it was the one thing that improved their quality of life significantly, and that was still an acceptable trade-off. So that sort of risk-benefit calculation becomes very individual.
Yeah, just a side question: can risperidone be used as a PRN medication instead, or?
Well, it can, but it may not. Again, it would depend on what's the situation. What are the issues that we're trying to fix? It may be, depending on what the issues are, it may be useful or even more sensible to use it only as a PRN, or it may make no sense at all. Like we may not realistically expect that the child's going to have the PRN multiple times a day. That's what we're going to expect. So then in that case, we might as well give them like a regimented, regular dose. But in some cases, yes, we use risperidone only as a PRN, only as needed.
Yeah. Okay. Thank you. And all right. I think this is a repetition. Okay, this one from Lynn again. For tantrums or irritability that is impacting quality of life, is the first step a BA or a MATS, like behavior consultant, I think, or MATS, if other health concerns?
I was trying to keep track of in the chat of which questions you are, but because I'm very visual, can you repeat it again then?
Oh, from Lynn, for tantrums, irritability that is impacting quality of life, is the first step a BA or meds?
The first step's ABA or meds?
BA,
oh,
yeah.
Or medication.
Yeah, no, the first step. So that was a bit maybe what I was implying in one of my slides, like on number 4, I've put like for disruptive behaviors, non-pharmacological treatment are always preferable. So it may be good to get your GP pediatrician to have a look at the situation to see if, again, if there's any source of pain or discomfort. I should add, I've spoken of GP or pediatrician. The other person that can have a role in pain or discomfort that causes disruptive behaviors is the dentist. So that's actually not uncommon that we have like children with growing slowly, getting worse, who are very resistive to dental hygiene and whatnot, and they have a big procedure done under anesthesia and it's gone after that. So have your consult with your primary care provider about anything physical going on, and it could be it's always good for them to do a mental health assessment to see if there's any actual comorbid psychiatric diagnoses such as an anxiety disorder or ADHD that could be contributing to those disruptive outbursts, and then the treatment. There are psychotherapy treatment for anxiety in children with autism, but for ADHD or for refractory anxiety, then I would say probably the first line intervention would be specific medications for those conditions. And if none of those things are present, like we don't think there's any physical cause of pain or discomfort, we don't think there's comorbid ADHD that will require treatment or an anxiety disorder, but there's still a pattern of impairing outbursts, then interventions that might be useful before we move on to things like risperidone for aggression would be try to look at improving the child's functional communication if we think that's a factor in the outbursts. And number two, a behavior therapy assessment. I dare to say ideally with a behavior analyst, with a BCBA that has expertise in disruptive behaviors, and they're professionals, so their assessment. I'm interested in their opinion as to what they think the function of the behavior might be, as to whether they think that a behavior therapy intervention would actually realistically reduce those problem behaviors, and what would that behavior therapy intervention entail? Because sometimes behavior therapy interventions can have side effects. Maybe that's not the right word, but sometimes it's not realistic to do that. Yes, if we were to do that, the problem behaviors would reduce, but that's just not really realistic. So examples of where that might be the case, I'm thinking of very older, bigger child, teenagers who are physically aggressive, where we would expect that the behavior therapy intervention would reduce the aggression eventually, but at first we would expect the aggression to increase before it gets better, where that may or may not be realistic. Or sleep issues that may often, that we didn't talk about. One of the comments in the chat was to the effect of some topical lotion being applied and the child was sleeping well. So falling asleep is a conditioned response, meaning like we learn to fall asleep because of things we associate with having fallen asleep regularly, with those things happening. And that facilitates in the long run us falling asleep. So behavior therapy interventions can resolve a lot of sleep problems, but sometimes if one of the problems that occur at bedtime is the child calls loudly for the parent to come, and the parent wants to sleep and has to work, and we want to get rid of that. A behavior therapy intervention would be expected to get rid of that in many circumstances, but maybe that would also involve the calling getting louder and more intense at first, and maybe the family is living in a townhouse, and maybe that's just not realistic to undergo that. So there could be definitely in disruptive behaviors, as in other things such as sleep problems, I think the first step is often to at least get an opinion from a behavior analyst or a behavior therapist, and see how far that can go. And if no intervention is indicated from their perspective, or if it's not realistic or it's not successful, then that would be the time to look at potentially looking at medications for disruptive behaviors such as risperidone.
Question from Richard. Can mild autism be treated without medication?
Mild or severe autism cannot be treated with medications, regardless. So there are no, just to reiterate, there's no medication that will relieve or improve the core symptoms of autism, which are the social deficits. For example, the ability to have a back and forth conversation that incorporates the perspective of others. That would be like a higher end goal for a higher functioning autistic youth, for example. Medications are not going to impact that one way or the other. Improve eye contact in preschoolers, and medications are not also going to improve like restricted, repetitive, stereotype patterns of behaviors and interests. whether they're severe or mild. They're not going to improve that. Maybe the person is also wondering, maybe the person had a recent diagnosis of autism in their family and one of their child, and they're wondering what that implies, and whether my child's been diagnosed with autism, does that mean they're going to end up on a bunch of medications? I would say no. So I would think it is the case that the majority of children with autism, you know, I'm making it safe by saying 50% or more of children with autism, I wouldn't go further as to telling you how much, but I think it's safe to say that the majority of children with autism will not need psychiatric medications. And none of them will need them for their symptoms of autism.
Okay, so I think we're running out of time, but I'll ask this last question. And for the rest of the question that is not addressed, I'll send it over to Dr. Proulx. Hopefully he will send us the answer and I can email everybody individually. And the last question we have is, how can we make kids taking pills?
Oh, there is an excellent, just go back to their website. If you give me 1 second, I will actually find it right. You can talk to your occupational therapist about that, or sometimes some behavior therapists will come up with a plan to teach them. But some parents have been quite successful at just doing it on their own. And I'm looking for the Autism Speaks website has a really good just video that just demonstrates how to do a little sort of desensitization teaching program at home. And of course, because I'm now looking for it, it's easy to find, but of course, because I'm specifically looking for it in a time constraint, I'm not able to find it. I wanted to share screen and show it to you, but yeah, just go to the Autism Speaks. I think the autismspeaks.org website has a little video to get you started on teaching them to swallow pills whole. I believe the Kelty Mental Health Center also had a separate sort of handout on how to teach children to swallow pills. That was more for all children. And sorry, I cannot find it either, but certainly the Autism Speaks has a little video like on one of their pages. If you just look up, search on their website, like somewhere around the resources for medications, there's an excellent video demonstrating with a child and a parent how to teach them. Another thing I would say is sometimes there's options where the child doesn't have to swallow. Of course, as a physician, I'm always grateful when parents go to the effort of teaching their child to swallow pills whole, because that expands the possibilities of medications, including potentially ones with less side effects, you know, like where if a child absolutely cannot swallow any pills, then we're more restricted. But it doesn't mean that medication treatment is impossible. It's going to be difficult with any long-acting medication where there's a proprietary packaging in the capsule that's with a mechanism to slowly dispense the medication through the day. That's going to be, we cannot sort of then we're stuck having to swallow it whole as it is, as the manufacturer instructs. But for immediate acting medications, we can also often get them compounded as liquid through a compounding pharmacy. So there's other options, but it's always best if you can manage to teach your child to swallow pills whole if they have to go on medications.
It's like, that means not all pills can be crushed and then mix it with liquid?
No, that's always, you should always check, you know, your pharmacist is really even more than your doctor. Your pharmacist will be the ultimate person that you can always check with them, but also ask your doctor before you leave with the prescription. Some medications, you cannot do that. Some of them, as I mentioned, has to do with the long-acting slow release mechanism, but for other medications, even immediate release, it's because of it may increase the risk of GI side effects, for example. Yeah, so, but there are options. Some are commercially available, a limited number of them are commercially available as chewables or syrups, as liquid, but if they're not, otherwise we can sometimes get them compounded as liquid. But I would say it often is, a lot of families have had like, surprising success teaching their kid to swallow pills whole, where it's been the least of their challenges. That one was quickly dealt with, and there's a little video on the Autism Speaks website, like I said, that's actually, I think, really helpful for that.
Sure, yeah, we'll look for that. And I think we're running out of time. And thank you again, Dr. Prue, for being with us today. And as like we've learned so much from you, and still a lot coming up that I'll send over to you. And hopefully we can arrange another session to talk more about medication and other pharmaceutical treatments for autism and comorbidity. And for now, if you have any further questions, just keep sending it to me and I'll just forward it to Dr. Prue, looking for answers from him. And until next time, have a good one, everybody.
All right. Take care.
Bye.
Thanks. Bye-bye.